Hello, my name is Lauren Zerniak, and I am a mental health trainer here at ViaQuest. Today, our topic for this training is going to be understanding obsessive compulsive disorder. Our objectives are to define and explain what behaviors make up a clinical diagnosis of obsessive compulsive disorder, or OCD as we may refer to it later on. To name two mental health disorders that a person with obsessive compulsive disorder may also experience, to gain an understanding of the do's and don'ts when encountering individuals with obsessive compulsive disorder, and identifying positive supports for working with someone suffering from obsessive compulsive disorder in a long-term care setting. Many people wonder how many out there actually have OCD, and the answer may surprise you. On average, between 1% to 2% of the worldwide population has OCD. Our best estimates are that about 1 in 100 adults, or between 2 to 3 million adults in the United States, currently have obsessive compulsive disorder. This is roughly the same number of people living in the city of Houston, Texas. A proper diagnosis and treatment, on average, it takes about 7 to 10 years for individuals with OCD. Potential precursors for OCD include having a close family member who also has the disorder. It's estimated that approximately 25% of individuals with OCD have someone else in their family who also suffers. And childhood trauma or abuse may increase the risk of developing OCD later in life. OCD is recognized as a disability. It is actually one of the top 20 causes of disability worldwide. And research suggests that OCD symptoms can be triggered or worsened by stress. I love the quote on this slide that says, "Being a neat freak is a world away from the torture of OCD." Because many people think of OCD as just having a somewhat excessive need to be orderly, clean, and organized. And while there is some validity to this, and some people with OCD are concerned with these things, some are actually unorganized and unorderly. It doesn't look exactly the same for everybody. What people seem to think OCD is, but really isn't, is keeping your room very clean and organized at all times. Only specific things can be stored in specific containers. Your shoes have to go in that same spot every day. But beyond people's misunderstanding about what those with OCD are like, people often attribute their own quirks and specifications to mild OCD. We can have a preferred way of doing things and be highly organized in particular without having OCD. Truthfully, OCD is not pleasant. It's not desirable, and it's not a compliment. In order to meet a true clinical diagnosis of OCD, there must be the presence of obsessions, compulsions, or both. Obsessions are repetitive thoughts, urges, or images that are experienced as invasive and unwanted, and that in most people cause anxiety or distress. The person tries to ignore or suppress such thoughts, images, or urges, or to counteract them with some other thought or action, i.e., by performing a compulsion. Compulsions are repetitive behaviors or mental acts that a person feels driven to do in response to an obsession or according to rules that they make up in their own head that must be done exactly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to prevent, or they are excessive. The obsessions or compulsions are time-consuming, meaning more than 1 hour per day, and negatively affect things like relationships or their jobs. Obsessions are ideas, images, and impulses that run through a person's mind over and over again. A person with OCD doesn't want to have these thoughts and finds them to be bothersome. Despite this, they can't control them. Sometimes these are thoughts that occur occasionally and are mildly annoying. Other times, a person who has OCD will have obsessive thoughts all the time. Obsessions can be external or internal. External obsessions are things like contamination, objects, smells, asymmetry, or mismatched items. And then there's internal obsessions. This might be things like doubts about one's sexual orientation or doubts about their romantic partner. In order to determine if something is an obsession, one must always ask themselves, are these thoughts intrusive by nature? Some types of obsessions include obsessing over fear of dirt or germs, thinking evil or sinful thoughts, or harming a family member or friend, disgust with bodily waste or fluid, worry that a task has been done poorly, even when the person knows this is not true, thinking about certain sounds, images, words, or numbers all the time, a need for constant reassurance. Symmetry, needing things just so, even or lined up a certain arbitrary way. Aggressive, most commonly focused on inadvertent harm, such as being responsible for a fire or break in. Somatic, exaggerated fears of contracting a serious illness, such as hepatitis or a brain tumor, even in the absence of any identifiable high risk. People who have OCD try to get rid of the nervousness and anxiety they feel from obsessive thoughts by performing certain behaviors that follow rules or steps that they make up for themselves. These behaviors are called compulsions. Compulsive behaviors are sometimes also called rituals. So, for example, a person who has OCD may have obsessive thoughts about germs. As such, the person may wash their hands repeatedly, even if they're already clean. Performing these behaviors usually makes the nervous feeling go away just for a short time. And when the fear of nervousness returns, the person who has OCD repeats the routine all over again. The purpose of compulsions is either prevention seeking, I want to stop something bad from happening, or reassurance seeking, I need to know the bad thing didn't or will not happen. And compulsions can be either physical or behavioral, or cognitive/mental. So physical compulsions would be things like cleaning and grooming, like washing hands, showering, brushing teeth over and over again. There may be checking drawers, doors, locks, and appliances to be sure that they're shut, locked, or turned off. Repeatedly turning the stove on and off. Driving around the block to ensure that they didn't hit someone. And then repeating actions such as going in and out of a door, sitting down and getting up from a chair, touching certain objects several times, repeatedly going up and down the stairs or flushing the toilet. This is typically done to cancel out a bad thought or until it feels right. Ordering and rearranging items in certain ways, folding clothes just so, or arranging all cans in the cupboard so the labels are facing out, or saving newspapers, mail, or containers when they're no longer needed. This could potentially lead to hoarding, which we will get more into later in this training. And some of these cognitive compulsions would be ruminating thoughts, like trying to figure things out or figure out their meaning, counting to a certain number over and over, or maybe performing certain actions arbitrary number of times, like tapping each foot 4 times when getting out of bed. Or they could be reassurance seeking, requesting or demanding reassurance from others to alleviate anxiety or doubts. So to understand the relationship between obsessions and compulsions, it goes like this. A person starts with having a worrying thought or an obsession. This might be something like, I touched the door handle of the public restroom. Who knows what germs I've picked up? This leads to a rising feeling of anxiety. And the thought transitions into, I might pick up an infection if I don't clean my hands now, which then triggers compulsions to urgently do something to neutralize the worry. I'm going to use a tissue to open the door and go back to wash my hands repeatedly until they feel they are clean. It's important to note that compulsions are not connected in a realistic way to the feared event or are significantly excessive. After the compulsion, it brings some relief, but this is usually temporary. The person may go back to having the same anxious thoughts and continue with this vicious cycle. So to really highlight and illustrate the relationship between obsessions and compulsions, I'd like to show this video, which is looking at living with OCD with Chad here.
1, 2, 3, 4.
1, 2, 3, 4.
1, 2, 3, 4.
Everything I do in my life right now is a sort of OCD ritual.
Okay, as I'm passing these cars, I'm looking at them and going, normal car, normal truck.
My biggest fear has to do with an El Camino. When I see an El Camino or hear the word, I have to wipe off the El Camino's bad luck. The longest period of time I spent wiping off the bad luck was close to 10 hours.
Chad's OCD was a big reason why we split up. He's too consumed with himself to care for anyone else. He needs help, and he can't do it alone.
When we do exposures, you're going to feel those symptoms go up and peak, and ultimately it's going to come down without you doing those compulsions.
Sometimes you want to die because you have to keep doing these
Things over and over again, and you can't stop. And I've been trapped in this for like 25 years, man, of my 35 years. I just want to be free, and I want to be normal, and I don't want to do this stuff anymore.
One, two, three, four, 4, 4. 1, 2, 3, 4, 5, 6, 7, 8, 9. 1, 2, 3, 4, 5, 6, 7, 8, 9. Looking to the south, east. Gotta do it again. 1, 2, 3, 4.
When I wake up in the morning, the rituals begin right away, and everything I do is dictated by the OCD.
Plug it in, and hopefully I don't think of something bad. If I do, I have to unplug it. Look up, because looking up is good. And then do it again.
If I don't do rituals, I feel like bad things will happen. And so a way to prevent the doom or the bad thing, I do the rituals.
Northwest, good, very good. Southeast, good, very good. Southwest, really bad. Keys are going that way. The keyboard is usually a little skewed. If I put my phone here, it has to be. These inhalers have to be. The mouse has to be facing northwest, especially the pick, the guitar pick. Otherwise, something bad to the band will happen.
Logically, I know that it's a superstition and that the universe doesn't work that way. But on the other side, the OCD brain comes in and says, oh, no, this is real. We got to do this. And it's so compelling, you have to do it.
I avoid changing my clothes because I got to put them on over and over again, especially socks. I haven't changed my socks in a long time. 1, 2.
I was doing stuff like taking on and off clothes, flicking lights on and off hundreds of times.
That's 3 times, so I got to do it one more time to make it 4. 1, 2.
At the age of 16, I was diagnosed with OCD, and after I got treatment the first time, my OCD almost completely disappeared. It was wonderful. It was like enlightenment, but it only lasted till I was about 29, and then it came back, just like the therapist said it would.
Now, see, those were off while I did that, so I've got to put them back on again.
How come you can't leave your apartment? You said to me...
Well, because at any moment, one of those things could drive by.
Oh, because El Camino's.
Yeah.
Is that just for El Caminos?
Like, don't even talk about it, because then I have to do it.
Yeah.
And the whole El Camino thing started because one day in the car, an El Camino drove by us,
And my buddy Russ was like, you gotta wipe that off. And I was like, what? He's like, wipe off the El Camino or something bad will happen. With someone like me, I take that and just spin it way out of control, and it becomes this huge, multifaceted ritual. I have done it for 10 hours straight, and that's the longest I've done it.
Seems like Chad is at one of the more difficult points in his life with the OCD. It's such a big part of his life, I don't know where he's gonna end up without treatment or help.
Sorry.
Everything about it breaks my heart.
Every car I've got to basically check. Is that a normal car? Normal car, good, it's safe. Normal pickup truck, safe.
Holy! There's one right there, mother... Holy...
See, man? At any point, one of those will drive by. I feel full of anxiety. I saw the thing that, damn, I can't even talk about it, or I have to start rubbing again.
Damn, those things are everywhere. You would think that no one would drive that anymore.
Yeah, I'm totally soaked with sweat. My heart is beating really fast. You just gotta take deep breaths, 'cause it's like you're hyperventilating. Now, see, the thing is I will definitely tonight go back and do my ritual of rubbing it off and facing northwest and looking at the numbers and singing the song in my head that has to be sung all night long. I think I have a lot to offer, but with this stuff, there's nothing. It's completely stupid. It's completely stupid. I'm really angry about it. I can't do anything. I can't stop it.
I'd give anything to be free from this man.
I think I'm completely crazy. It doesn't stop, and it's not my fault.
So we can see there, Chad, some of those obsessions that he had, thinking of things as good or bad, right? Northwest, very bad, or Northwest is very good, whatever it may be. Or if he plugged the toaster in and he was thinking a bad thought, he had to unplug it and do it again. And then the El Camino being bad luck, which then led to the compulsions. He has to be looking a specific direction. Objects have to be pointing specific direction. Spinning and tapping his toothbrush, socks on and off, wiping off the El Camino. It really illustrated for us in that video, that OCD comes with other mental health conditions as well. So comorbidity means a disease or medical condition that is simultaneously present with another in a patient. We'll talk about more specifics of some of these, but I wanted to just highlight how OCD can be bad enough in and of itself, but it often brings with it more difficulties than just the obsessions and compulsions. It was very obvious with Chad how depressed he was about this and how much anxiety it really drove in him. Hoarding. Okay, so hoarding is not the same as collecting. Collectors typically acquire possessions in an organized, intentional, and targeted fashion. Once acquired, the items are removed from normal usage, but are subject to being organizing, admired, and displayed to others. Acquisition of objects in people who hoard is largely impulsive, with little active planning, and it is triggered by the sight of an object that could be owned. Objects are acquired by people with hoarding lack a consistent theme, whereas those of collectors are narrowly focused on a particular topic. In contrast to the organization and display of possessions seen in collecting, disorganized clutter is a hallmark of hoarding disorder. Elderly people may have even more difficulty getting rid of their stuff because those items represent memories. Also, for those who experienced difficult financial situations in the past, such as like the Depression, there may be fear associated with letting go of anything. And finally, some elderly people simply don't have the energy or the mobility to keep up with their possessions. As a result, they let things pile up rather than asking for help. Seniors who are depressed or lonely tend to hoard things that remind them of happier times. They may also hoard because it gives them a sense of control when control over their physical and mental facilities may be failing. So, what can we do when a resident hoards? Include the resident in the cleanup. So, secretly throwing things away or doing a big cleanup when the resident is out of their room only causes mistrust and makes them cling even more tightly to their possessions. This might be something you see when out of town family members do, like when they come to visit. This is the worst thing that we can do. And while it may seem like a solution to the problem, the results won't last if we don't address the underlying issues. The resident must be part of the decluttering process. Protect the residents' rights because hoarding becomes a unique challenge in senior living communities because of residents' rights. There's a fine line that exists between providing care for our residents while not overstepping our boundaries. Some people don't see their hoarding as a problem, so they resist all offers to help. Don't push too hard. It's still important to allow the resident to maintain a sense of control and not to move too quickly. If you put pressure on them, it only increases their anxiety. This could cause the resident to halt the cleanup process and refuse further help. Involve mental health specialists. In some situations, a referral to a psychiatrist or other mental health professional can address the underlying mental health problems, such as that depression or that anxiety. And work as a team. Every resident situation is unique, and it takes a team to address a hoarding problem. Besides the resident and their family, invite input from all the disciplines that you think could help. This might be housekeeping, social services, a physician, any other specialties. This results in the best plan of care for those residents. Tics. Tics are fast, repetitive muscle movements that result in sudden and difficult to control body jolts or sound. They're fairly common in childhood and typically first appear around the age of 5. They vary occasionally, they can start in adulthood. Tics are not usually serious and normally improve over time, but they can be frustrating and interfere with everyday activities. Tics are a hallmark presentation of Tourette syndrome, but person can have tics that have what looks like tics, but might not actually be. Let me explain more. If you happen to notice a resident develop a tic that they didn't have before, this could actually be tardive dyskinesia. Tardive dyskinesia is an uncommon side effect of certain medicines. People who develop this drug-induced movement disorder have involuntary, repetitive body movement. I'll show some examples of this on the next slide. Some risk factors linked to TD include people who are over 55, Black and female people who have gone through menopause are more likely to develop this problem. And there are certain health factors that increase your risk, including diabetes, HIV, substance use disorder, and traumatic brain injury. People who take medicines to treat certain mood disorders, gastrointestinal problems, or neurological problems like dementia, epilepsy, or Parkinson's may develop tardive dyskinesia. Most people take medication for years before developing tardive dyskinesia. Although rare, some people develop TD after they stop a medicine. So this video has no sound, but I want to include it so that we can kind of see what some of this TD presentation. Facial and oral movements while sitting. So this guy and blinking his eyes and his lips moving. Jaw movements while performing activation maneuver. Her hands moving. Trunk movements while sitting with hands hanging unsupportive. His hands are hanging unsupportive and he's got these trunk movements. Upper extremity movements while sitting with hands on knees. See how her hands twitch like that. Upper extremity movements while sitting with both arms extended. Her hands are out and they're shaking. Lower extremity movements while sitting. You see that very subtle tap of her foot. Foot movements while performing an activation maneuver. So she's moving her hands, which causes her feet to move involuntarily. Facial and oral movements while sitting. Her lips are kind of going in and out. Jaw movements with mouth open. You can see it's kind of sliding back and forth and kind of going up and down a little bit. Jaw movements while performing an activation maneuver. So she's moving her hands up above her head, which is causing the jaw to move. Tongue movements while sitting, that tongue popping in and out of the mouth like that. So I also wanted to mention too how obsessive behaviors and dementia play a hand with each other. So OCD and dementia share some symptoms which can make diagnosis more difficult. OCD usually develops by early adulthood. So if an older person starts exhibiting symptoms, this may in fact be an early sign of dementia. So symptoms you may notice include repetitive behavior, rituals and routines, becoming excessively worried, maybe about potential threats and dangers like germs, disease, accidents, or being attacked, keeping things in a specific order or neurotically neat and tidy. There may be hoarding, muttering to themselves and counting under their breath, and becoming more superstitious. Many symptoms of dementia can cause a person to act in a similar manner to a person suffering with OCD, sometimes unintentionally and sometimes as a way of coping. Some reasons include poor memory that can result in the person repeating actions or checking that they have done it multiple times. Poor memory can also cause them to become fixated on subjects they are anxious about, as they can't remember the answer to their questions or concerns. They can become obsessed with particular topics, sometimes for the aforementioned reason, and sometimes because this subject or activity is familiar and they feel confident that they can still do or talk about it. They may have difficulty with understanding what time of day it is and where they are, and that can lead to a fixation on knowing what the time is or carrying out exact routines at certain times. Challenges with reasoning, as well as a drop in confidence and feelings of powerlessness, can result in increased anxiety and an obsession with things being lucky or unlucky. There is a lack of confidence due to losing certain abilities and can push them to repeat tasks to ease this anxiety and to feel useful, such as obsessive cleaning. Delusions and hallucinations can increase their anxiety and need to carry out compulsive behaviors to feel better. So just because we see a resident have OCD-like symptoms does not necessarily make it actually OCD. So to support a resident with dementia and OCD-like symptoms, get them to talk about the obsessive behaviors if they're open to it. They may need time to open up, but doing so without being judged can help both of you. Gently ask them why they need to complete the certain rituals and reassure them that nothing bad will happen if they don't, but do not forcibly stop them from doing them. A change of scenery can limit routines and rituals. So, for example, if they have an extensive routine they must perform before they eat dinner, maybe taking them to eat somewhere different, like over with a friend or in their room, um, may help them. But going back to OCD, when a resident does have OCD, don't get involved with the person's obsessions and rituals. This only makes them worse by acknowledging them. This then gives the compulsion some kind of credibility and worth, which they do not deserve. Detach yourself from them with love. Don't refuse in an angry or aggressive way. Don't be tempted or persuaded by tears or emotional blackmail. The sufferer is just that, they're suffering. But giving in to their compulsions will only make their symptoms worse. Don't give up on the sufferer. OCD is a very difficult illness for anyone to understand, and it can be hard for someone to know how to best behave when with that person. Educate yourself so that you are better equipped with that knowledge. What you to do when a resident does have OCD, do be supportive. Talk about the obsessive compulsive disorder. Try to be understanding during stressful times and praise any improvements made during treatment. Do be positive. Remember, OCD is no one's fault. OCD is an illness. It's not part of someone's personality. And do be consistent. Set rules for behavior and stick to them as much as possible. It is important to keep a normal routine. All communication about rules and guidelines must be consistent, clear, and simple. So let's take a look at a really unique approach that Tasha Johansson, I apologize, used to help her daughter who suffers from OCD.
A recent social media trend involves posting pictures of perfectly clean, color-coded, organized to a T spaces, followed by the hashtag OCD, or a short comment like, "I'm so OCD, LOL." The phrase is used tongue-in-cheek as a joke. I know, I get that. Sometimes even as something to aspire to or celebrate. Look at this, isn't it great? Don't you want some of this? My daughter Breland has OCD, but I gotta tell you, it's nothing like the Instagram version that you post and hashtag. OCD, or obsessive compulsive disorder, is neither a verb nor an adjective as you use it on social media. You gotta know that. It's also a serious condition, a disorder that results from a chemical imbalance in the brain, and it is never a choice. Perhaps I can paint the picture of what the OCD that we came to know and live with looked like. One night, about 9 o'clock, Breland came home from work. It was a freezing cold night in the dark of winter, and it wasn't until after about 3 hours of her coming home that the OCD kicked in to convince her that she'd hit someone on her way home from work. She decided she had to go out and check the roadsides and ditches. So the thing is, going back to check to see if she'd hit something or someone, that was not uncommon for Bree. Driving was difficult and stressful for her. She was obsessively concerned with hurting someone with her car. The 3-mile commute to her waitress job could take her upwards of an hour due to the repeated looping back and forth to check her path. You would think she would have known every pothole in the road, but the OCD demanded that those bumps she felt as she was driving were not potholes, but people. So this night, as Breland went to leave the house, her then fiance tried to restrain her. It almost cost him their engagement. Her dad led her through good, solid logic of why going out and checking was absolutely not necessary. It was at this point that Breland threw back her shoulders in a fit of rage and tears and emphatically announced she was driving to the police station to turn herself in if no one would let her go out and check the roadsides for bodies. Here was this gentle soul who would never intentionally hurt anyone, who honestly believed she'd killed someone, left them injured and alone in a ditch in the dark to die in the freezing cold. Just imagine her anguish. It was moments like this that made me hate the OCD so bad I could literally taste it. But years of experience with this monster led me to deal differently. So I said, Bree, maybe you should go turn yourself into the police. The OCD was startled, shocked, and left Breland without the support of a retort. So I continued, what do you think the police are going to tell you, Bree? She insisted they would throw her in jail, and she deserved to be there. Again, I agreed to a point. Breland, I think they're going to see that you need to be removed from society for a little while, but not thrown in jail. They'll be able to tell you're already living in a cage and being managed by a monster. More than likely, they'll suggest to stay in a mental hospital where you can get the help you need. And Breland, you need help to beat this. The OCD was outwitted long enough for Breland to regroup and summon the skills and strategies she had spent years practicing. She didn't go out, check the roadsides that night, nor did she go turn herself into the police. But let's note, reason nor restraint were effective for her, but it was the strategies that she had learned and practiced for years that allowed her the escape. Breland was first diagnosed with OCD when she was about 8 years old. And as parents, we really struggled to understand and find ways to help her battle. What we arrived at was a strategy built on a simple analogy. We compared Breland's OCD to a monster. Not the kind of monster she needed to fear, but a hungry monster that constantly demanded to be fed. The monster represented Breland's obsessions. They came into her brain uninvited, set up monster camp, or an intrusive thought loop that just played over and over. And the way it wanted to be fed was through the compulsions, or the behaviors that she needed to perform perfectly and ritualistically. The thing is, performing those behaviors never satisfied the monster, ever. In fact, the only thing that did is to make the monster grow bigger and stronger. And bigger monsters are hungrier monsters and grow more insistent with size. So we told Breland the way to quiet the monster was to starve it. Hungry monsters grow weak and eventually tired. So the longer she could delay feeding it or performing the rituals it asked for, the quieter it would become over time. Starving the monster worked, but it required Breland to make a very difficult decision between living for a short time in an extreme and excruciating amount of discomfort and anxiety, or living a lifetime with the monster roaring. It's a strategy that offers hope that things can get better. It offers compassion for the pain and suffering associated with the OCD. It offers empowerment for those with OCD to know that there's something they can actually do about it, and encouragement for them to keep doing it. The benefits are far-reaching, not only for those with OCD, but those who suffer alongside them, and even those whose only connection to OCD is a hashtag, because after all, we all have monsters that need to be starved, don't we? Before we could engage in starving the monster, we had to acknowledge it in a way that was honest accurate, and non-judgmental. Truth be told, that's actually what we did differently than others with OCD. We didn't hide it. We called it out, externalized it, and acknowledged it in front of the world, because we believe you can't be beat by something you don't fear. Should I repeat that for you? You cannot be beaten by something you do not fear. I'm not sure whether it was starving the monster or calling it out that allowed Breland to live a happy and fulfilled and productive life. But this I do know, a monster lived in our house, and we were not afraid. It also allowed Breland to live a happy and fulfilled life as a productive member of society. In our family, we don't believe in doing helpless or hopeless. In fact, that's not even allowed. So we help others today starve their monsters and slay their monsters. It's a cause you can take up too. You can't starve someone else's monster if it's not yours to starve, but you can be the one person who can see non-judgmentally their OCD for what it is and what it isn't. It isn't something they choose, and it isn't something that brings them joy. Today, I'm a member of a large OCD support community online. And those people in that group who truly suffer with OCD, they want you to know something. Those posts that you hashtag and post on social media, those are not representative of the real OCD experience. But they can't tell you this because they hide their OCD from you. Do you really think if their OCD was so great as those posts that you post, that they'd feel like they need to hide it from you? Can we just acknowledge the irony here? Social media glorifies OCD while society continues to stigmatize it along with all other mental illness. Both of these views stem from a lack of knowledge and understanding. We are not helpless to change that. There is something we can do. And I promised those people in that group that I would do something for them tonight. So please allow me to be their voice on this stage tonight. World, OCD is not something to aspire to. And it was not something we were going to allow to ruin our daughter's life. Like I said, it is our cause today to help others slay their monsters. It's a cause you can take up too. You can be that one they can trust. You can be that one that will empower them to keep the monster out in the open where they don't need to hide it and they don't need to fear. Should you choose to take up this cause, can I suggest 2 alternative hashtags that you could use in place of the ones you have been using that would send a signal to those with OCD that you want to understand and you're willing to support? I'll just tell you from personal experience that seeing these 2 hashtags as a show of solidarity and support would be amazing, because we didn't have the support we needed when Breland was first diagnosed. In fact, we had to own the responsibility to rally that support by telling family and friends and teachers and everyone else about OCD. The hope that it would give those with OCD to see your show of support would be just amazing and incredible, and I guarantee you it would change their lives. Thank you.
The intent of the video was to illustrate this analogy of OCD being a hungry monster. How by not feeding the monster, aka performing the compulsions, it can help alleviate the obsessions. Looking at OCD as a type of external force acting upon a person and not as an embedded part of who they are can be a really empowering thing for people who suffer with it. I do not encourage you to use that kind of reverse psychology type approach the speaker used with her daughter, where she encouraged her to turn herself into the police. Like she can do that because that was someone she had a non-professional relationship with, since it was her daughter's. So she had a different kind of understanding of how her daughter would respond to it. That is not the kind of approach that we would want to take with a resident in a long-term care facility where we work at. For ways you can help in a long-term care setting, firstly, you can do exactly what you're already doing today, which is learning more about OCD. Try to talk to the person about their OCD. No information will be able to fully explain what that resident is going through in the same way. Remember, everyone's experiences are different. Try to keep an open mind. OCD can be complicated and confusing. Your resident may tell you things that worry or don't make sense to you. So try to remember that they may have kept their experiences secret for a long time, and they may be worried about your reactions. There's still a lot of stigma about OCD. So when and if you can, challenge that stigma. If you hear or see someone talking about it in a way that stereotypes or trivializes it, letting them know how people with OCD may choose to suffer in silence because they don't want people to think that they're being trendy. The second way that you can help in a long-term care setting is to help them manage the compulsions. So managing compulsions can be very complicated and difficult thing to do, but it's an important part of managing OCD. There are some things you can try to as help. Agree on an approach that feels right for you both. For example, you might decide to say, we've agreed I won't answer questions like that to help you manage your OCD. Resist giving reassurance. Seeking reassurance is a very common symptom that often involves those around them. So for example, they may ask you whether they did something wrong, or they may ask you to confirm that their memory of an event is true. Try to gently explain that you don't want to make their OCD worse by reassuring them. Try not to use logic or to reassure them. For example, if they're worried that they've hurt someone, you might try to help by explaining all the reasons that this is unlikely to be true. This might reassure them in the short term, but may make them feel the need to seek this reassurance again. And use a code word or sign if it helps. You could plan a word or a symbol between you two to symbolize that OCD. And this may be useful to use in the moment when someone is distressed and struggling to explain their feelings. Suggest things that you can do together to take their focus away from their OCD to help distract them. And this could be things like going for a walk, doing a puzzle, finding a show they may enjoy. Compromise with the compulsions you help with at first. So for example, if you help them with a number of compulsions, you may need to slowly reduce the number you do. Help to delay the compulsions. Rather than offer reassurance straight away, you could ask them to wait a set amount of time before you talk. Try to increase the delay a little bit each time. Next, you want to be sure the person and whoever else is part of their care team work together. When they're feeling well, talk and plan for times when they might struggle in the future. Always include the person you're trying to support when you're making decisions about how to best support them. It might help to write your agreed plans down and try to work together to be consistent if you're part of a group supporting someone. Use visualizations. It may help you think of OCD as something or someone separate. You could suggest that they give their OCD a name that both of you use. This might help you to explain that it's the OCD you don't want to help, not them. Like mentioned in the previous video, how they viewed OCD as a monster, and by not performing the compulsions, they were starving it and making it weaker. Try to avoid minimizing their feelings or saying things like, just don't worry about it, Instead, try to acknowledge they're struggling right now and try to sit with their distress. Accepting difficult thoughts and feelings is a part of managing OCD. Rather than trying to fix the problem or make their distress go away, try to help them accept it and sit with it. And as we've gone through, working with someone with OCD can be very taxing, both mentally and physically. It's important to be kind and patient with them. Try not to judge and remember that their fears are very real to them, even if they seem unrealistic, irrational, or extreme to you. Celebrate the wins with them, no matter how small. If you've noticed that they've coped with a situation well, tell them about it. Remember that they're trying. Coping with OCD is not straightforward. Someone may be managing their symptoms well for some time and then have a setback. Encourage them to be compassionate with themselves. OCD can come with a lot of guilt and shame. Encourage them to treat themselves with the same kindness they would treat somebody else with. Lastly, because OCD has so many complexities, encouraging the person you work with to get professional treatment can make all the difference. The best outcome is a combination of therapy, medication, and exercise. Just like how exercise helps with managing anxiety and depression, it can also help with managing OCD symptoms. If your facility does any kind of group fitness activity, encouraging them to attend or attending it with them until they're comfortable. For the therapy and medication part, ViaQuest is available to provide your residents with both without them ever having to leave your facility. To get started, a resident will receive a psychiatric evaluation with one of our nurse practitioners. After they are established as a client, we can provide a wide range of services, including therapeutic behavioral support, individual psychotherapy, and medication management. Therapeutic behavioral support, or TBS, focuses on symptom management, life skills, and coping mechanisms. Skill building, including social emotional stress management, anger management, and communication and interpersonal relationships. And then crisis management skills. With individual psychotherapy is typically done in person on site with a trained licensed counselor or social worker. They'll help support your residents getting to the deeper issues of what's driving this behavior. And ongoing medication management with a certified nurse practitioners and nurses will oversee psychiatric medications that can decrease a wide array of mental health conditions, not just OCD. That brings us to the end of our time together. Thank you so much for watching.